I appreciate the invitation to participate in this year's conference. I've been charged with giving a surgical perspective on pancreatic cancer. My primary objective is to outline how we currently think about the multimodality treatment of local or local regional pancreatic cancer patients and discuss some of the more recent data that has been published or presented regarding the management of these patients. And for the sake of time, I'm going to jump right in. At the time of diagnosis, patients with pancreatic cancer can be considered to fall into one of four major groups based on their clinical staging. Unfortunately, the majority of patients have unequivocal radiographic evidence of metastatic disease at diagnosis. For those without obvious distant metastases, there are three groups to consider: locally advanced unresectable tumors, where there is involvement of surrounding blood vessels to the extent that tumor resection is not possible, and then tumors where there is a potential path to resection, and these include borderline resectable and resectable tumors. This morning, we are just going to focus on the management of patients with borderline resectable and resectable disease. The definition of borderline resectable pancreatic cancer is a bit of a moving target, but over the last few decades, as there has been increasing incorporation of vascular resection and reconstruction during pancreatectomy, this group does represent a growing proportion of pancreatic cancer patients. The definition of borderline resectable disease includes both radiographic and anatomic criteria, as well as non-anatomic considerations. From a radiographic standpoint, borderline resectable tumors have abutment to critical blood vessels to the extent that there is a high likelihood for the need of vascular resection and reconstruction, as well as significant concern for a margin-positive resection. Admittedly, there is some variability between individuals and institutions about these definitions, but in line with NCCN guidelines, we would consider borderline resectable tumors to have the following: superior mesenteric vein or portal vein contour irregularity, narrowing, or short segment occlusion, for which there is an acceptable path for resection and reconstruction of the involved vein. With regards to arterial involvement, patients who have less than 180-degree abutment to the superior mesenteric artery, which permits the artery to be skeletonized along its adventitial surface at the site of tumor interface. There also may be solid tumor contact with the common hepatic artery, as long as it does not extend distally to the hepatic artery bifurcation or proximally to the celiac trunk, such that a short segment resection and reconstruction can be performed. And finally, for patients with tumors of the body or tail, there is still some that would include encasement of the celiac artery as borderline resectable. For these patients, however, tumor extirpation will require resection of the celiac axis. Permitting adequate hepatic arterial inflow can be preserved or safely reconstructed. However, even among NCCN panelists, there is some disagreement about whether to consider these patients locally advanced unresectable or borderline resectable. Aside from a strictly imaging standpoint, other considerations which have been used to deem patients borderline resectable include marginal performance status, markedly elevated CA19-9 levels, large tumor size or bulky regional lymphadenopathy, and indeterminate lesions seen on initial staging CT or MRI that cannot be fully characterized as benign or malignant and are not amenable to biopsy. Our current management of patients with borderline resectable cancer is in line with both the NCCN and ASCO consensus statements, and that we recommend that all of these patients are initiated on systemic therapy rather than undergo upfront surgery. The regimen chosen is based on performance status and germline testing, but most patients receive either modified FOLFIRINOX or gemcitabine nab-paclitaxel. Both during and following completion of intended chemotherapy, patients are clinically restaged. For those that progress during systemic therapy, further treatment is based on their symptoms, performance status, alter systemic therapy, and clinical trial options. For the patients who do demonstrate a radiographic response or stable disease at the time of restaging and who have an adequate functional status, our current approach is to administer preoperative chemoradiation therapy. Again, these are patients who, based on their imaging, we anticipate the potential need for vascular resection and reconstruction and are a higher risk for margin positive resection. Following chemoradiation, patients are again restaged and, provided no progression, will be offered exploration for potential tumor resection. This is a pathway that is used in many centers across the US. There are at least 3 relatively recent prospective single-arm phase 2 studies within the United States demonstrating the feasibility of this approach. The original Alliance trial, which was a multi-center study in which patients with borderline resectable tumors received 4 cycles of FOLFIRINOX followed by 50.4 gray IMRT delivered in 28 fractions. Of the 22 patients enrolled, 15 went on to resection, and of these patients, there was a 93% R0 resection rate and an 18-month overall survival of 70%. A subsequent study from the Massachusetts General Hospital, patients were treated with 8 cycles of modified FOLFIRINOX, and the course of radiation therapy was dependent on findings at the time of restaging. For patients with radiographic resolution of their vascular involvement, they received a 25 gray equivalent and 5 treatments of proton beam therapy, while patients who had persistent vascular involvement received 50.4 gray of IMRT and 28 fractions. Of the 48 patients enrolled in this trial, 32 underwent pancreatectomy with an R0 resection rate of 97% and a 2-year overall survival of 72%. Finally, in a recent report from the University of Michigan, patients received 6 cycles of FOLFIRINOX followed by 50 gray IMRT with concurrent fixed rate gemcitabine followed by 2 additional cycles of gem prior to resection. In this trial, there were 25 patients enrolled and 13 went on to pancreatectomy with an R0 resection rate of 100% and a median overall survival of 37.1 months. While these trials all have small numbers and again are single-arm studies, and there is some variation in the duration of chemotherapy as well as the total dose and methods of delivery of their radiation, collectively they demonstrate improved R0 resection rates and favorable survival outcomes when compared to historic controls. The Dutch Prio study was a phase 3 randomized trial in which patients with resectable or borderline resectable tumors were randomized to upfront surgery followed by adjuvant gemcitabine versus neoadjuvant chemoradiation therapy with 36 gray radiation delivered in 15 fractions with concomitant gemcitabine sandwiched between modified courses of gem. For patients who were considered to have resectable disease, there was no significant difference in overall survival or the R0 resection rate between the neoadjuvant therapy and upfront surgery groups. However, for patients with borderline resectable disease, neoadjuvant therapy led to a 4-month improvement in median overall survival and a markedly improved R0 resection rate. One of the main drawbacks of this trial in our current context is that the chemotherapy given was single agent gemcitabine, which is not what most of us would use at this time, and the radiation delivered was a bit unconventional. Nonetheless, the R0 resection rate of 13% and the median overall survival of just over 1 year among patients with borderline resectable disease who underwent upfront surgery clearly demonstrate that this group of patients should receive neoadjuvant therapy. The results of the Alliance 021-501 trial were recently presented at ASCO GI. This trial was designed to evaluate the contribution of radiation therapy to neoadjuvant chemotherapy in borderline resectable patients. The study randomized patients to receive either 8 cycles of modified FOLFIRINOX followed by resection, or 7 cycles of FOLFIRINOX followed by radiation therapy delivered as either 33 gray of 5 fractions of SBRT or hypofractionated image-guided radiation therapy to 25 gray and 5 fractions. Patients in both arms were intended to receive 4 cycles of FOLFOX postoperatively. Of the 70 patients randomized to RMA, 32 made it to resection. These patients had an 18-month overall survival rate of 93% and an R0 resection rate of 88%. These findings are an improvement relative to historic data and are consistent with the data seen in the aforementioned single-arm studies. Of the 56 patients in Arm B who did receive preoperative radiation, only 19 ultimately underwent resection. These patients had an 18-month overall survival of 79% and an R0 resection rate of 74%, which is not notably improved relative to historic data. These findings were somewhat curious to all of us. So based on the available data, we still have questions about the value of preoperative radiation for borderline resectable patients. I'm not sure that we can say that radiation is unequivocally beneficial in this group. However, it does not seem to be detrimental. Moving forward, we will need to better understand the appropriate techniques for the delivery and dosing of radiation therapy in pancreatic cancer patients. We also need to appreciate that these may be variable depending on tumor and patient-related factors, as well as local experience and resources. While the role of neoadjuvant therapy for patients with borderline resectable disease is widely accepted, its use in patients with anatomically resectable pancreatic cancer is not as well defined. Consider the following patient: a 67-year-old female who presents with painless jaundice and is otherwise in good health with a good performance status. Her CT reveals a 2-centimeter hypodense mass in the head of the pancreas without any contact with critical blood vessels. CA 19-9 in the setting of a normal bilirubin is 121, and at diagnostic laparoscopy, she has no occult liver or peritoneal metastases. How should we manage this patient? Certainly, the argument can be made that if surgery is the only legitimate chance at cure and the tumor can be resected with a straightforward operation, why not go straight to the operating room? And this is certainly a valid stance. However, we know that even for patients with stage 1 pancreatic cancer, outcomes are improved when patients receive both surgery and chemotherapy. The problem with the surgery first approach is that many patients fail to initiate or complete adjuvant chemotherapy because of delayed physical and nutritional recovery following pancreas surgery. These findings make a neoadjuvant approach attractive even in patients with resectable disease. For probably the last 3 to 4 years, we have been treating patients, most patients at least, with resectable pancreatic cancer with neoadjuvant chemotherapy. And this mirrors a trend that is being seen across many centers in the United States. The SWOG 1505 trial randomized patients with resectable pancreatic cancer to receive perioperative chemotherapy with either modified FOLFIRINOX versus gemcitabine nab-paclitaxel. Patients were designated to receive 3 months of chemotherapy before and after resection. A few interesting findings in this trial include that first, there was no significant difference in outcomes when comparing the two systemic therapy regimens administered. And second, that survival outcomes for these patients were similar to those in adjuvant therapy trials where patients underwent upfront surgery. An upcoming study to be on the lookout for is another alliance trial, which will randomize patients to upfront surgery followed by adjuvant FOLFIRINOX for 12 cycles, or neoadjuvant treatment with FOLFIRINOX for 8 cycles, followed by surgery, and then adjuvant FOLFIRINOX for 4 cycles. And then again, these are just patients with anatomically resectable tumors. So just a few take-home points that I'd like to leave you with. First, neoadjuvant therapy we feel is appropriate for patients with borderline resectable tumors. However, the benefit of radiation therapy in these patients remains unclear. Upfront systemic therapy in patients with resectable tumors has growing acceptance in the United States, but there are still questions to be answered. Most importantly, a well-coordinated multidisciplinary treatment approach is important for optimal outcomes in all of these patients. Again, I appreciate the invitation to be part of this year's conference and look forward to potential further discussion in the panel session.